kids and not liking being there.
When Kim came in and I was talking to them, and it's made it really frustrating.
Okay, well, I think we should.
She's like,
Okay, good morning, guys. Thanks for being here. I anticipate we'll see a few more people coming in, and hopefully a few people showing up in our connected rooms. But let's just go ahead and get started. It's informal. It's not a big deal. Yeah, let's see. We definitely want to make sure our audio is working for our GoToMeeting folks. Someone on GoToMeeting could let us know that you hear us.
Type in the chat box.
Type in the chat box or thumbs up. Seems like they're not hearing us.
Might be.
our doctors are just spending too much time. Do you see Mr. Premier? Prepared to help you.
Right, so how's the audio for our friends on GoToMeeting?
Anyway.
Let us know if you guys can hear us.
Yes, now.
Okay.
Done.
Okay, great. All right.
Thanks, Don.
Okay, so we'll go ahead and get started. Again, thanks to everyone for being here. I don't know if this means that you're not going out of town for Thanksgiving or tomorrow for Thanksgiving. We appreciate you being here. It's, I think, going to be a great meeting. So we're glad that you're here. And again, as I mentioned, we hope to see some people showing up in those rooms as well. All right, so here's our agenda today. We'll do our usual kind of introductions and some housekeeping, and then we'll move into our brainstorming. That's the opportunity for you guys to sort of network and learn from one another and share positives as well as cases that you're struggling with, etc. Around 9, we'll get started with a presentation largely from Beth Nordforce, who is care manager at Rainbow Kids around hospice and palliative care and goal plan. And then Gina Money will be the last speaker for the end of the meeting time, and then we'll wrap up close to 10 o'clock. And we do need to end promptly at 9:59 because that's when our recording ends. And so if anyone does join us from those other meetings, that's also when the connection to us ends. So we'll try and work for 9:59. All right, so I'm Mindy Tueller, and I manage the medical home portal, and I also facilitate these meetings, and I think most of you know me. See you all. Let's go ahead and should we start with our GoToMeeting, folks?
Yeah.
Okay, let's find out who's meeting.
Okay, we have Cecily Tillman on the phone. Can you introduce yourself, Cecily? Or not. We have Melinda Tibbles on the phone. Melinda, can you hear us? And if yes, can you please introduce yourself? Oh, Cecily, right. I'm a care manager at Memorial Pediatrics.
Great.
Hi, I'm Melinda Tibbles from Utah Valley Pediatrics in Panogas. I'm the care coordinator there.
Thanks, Melinda. We have Natalie Allen.
Yes, I'm Natalie Allen. I'm a nurse practitioner, and I work for our Integrated Services Program, Children's Special Health Care Needs.
Wonderful. Thank you, Natalie. Then we have caller number 3 and caller number 4. So please introduce yourself.
I'm not sure what number I am, but this is Dawn Bentley. I'm one of the QI specialists at UCCCN. Work with Gabby.
Okay, you are caller number 3, Dawn, just for reference. And caller number 4.
Well, I'll take this chance to just explain that if you do join us by GoToMeeting and you just call in rather than connect via the computer and, for instance, the phone, we can't see more than just that you're a caller. And so it's very helpful for us for records if we can connect a person with that caller. So if your only ability to join us is via the phone number for GoToMeeting, it would be super helpful if you would just drop me a quick email that said, "Hi, I joined GoToMeeting. I joined the meeting by the GoToMeeting phone number today." That would be very helpful. We're trying to do a better job of sort of keeping track of the attendance at these meetings. And while it's great to indicate that we have X number of callers from the meeting, it's even better if we can identify who those are. So that would be terrific. Okay.
So caller number 4, last chance.
The mysterious caller.
Mysterious caller. All right then.
Okay, yeah.
Well, I'm Gabi Baragoshi. I'm working with Dawn. I'm one of the quality improvement specialists at UPIC, and also working a little bit with Wendy on the medical home portal.
And why don't you go ahead and go next?
I'm Nicole Ray. I'm a patient navigator for the Huntsman Intermountain AYA program.
Welcome.
Thank you.
Sorry. I'm Beth Nordforce. I'm with the Rainbow Kids Palliative Care team at Primary Children.
I am Tomoko Tsukamoto. I am also a Huntsman Intermountain young adults and young adult patient navigator. I work with Nicole, and we serve patients between age 15 and 39 cancer patients.
Charlie Boss, I'm a care guide at Southridge Pediatrics.
I'm McKenna. I'm the care manager at Southridge Pediatrics.
Anna, manager at Southwest Children's Clinic.
I'm Hilda, a assistant with Integrated Services for Children's Special Health Care Needs.
Brett Christensen, program manager for Utah Department of Health Integrated Services program.
Mary Martinez, a care coordinator.
And Walt Torres with Integrated Services Programs with the
Greg Hawks with James Mason Centers for Recovery. I do community outreach.
I'm Cassie Crane. I'm the medical home coordinator at Wasatch Pediatrics, South Point.
I'm Katie Green. I'm the parent consultant with the Utah Parent Center and the EDDI program at the Department of Health.
I'm Kay Haynes with the resources on the medical home portal.
Chuck Norland, director of the medical home portal.
Allison Lewis, medical home coordinator with Wasatch Pediatrics, St. Mark's.
And Heather, medical home coordinator for the Wasatch Pediatrics in Draper.
And I'm Angie Richens with Alpine Pediatrics. I'm their case manager, their behavioral health manager.
I'm Gina Money, Utah Parent Center, Utah Family Voices.
All right, very good. Okay, so kind of just the usual housekeeping. We want to remind folks that free to get up and get food or use the bathroom anytime that even if you were in around here in bathrooms. I don't know if you all entered from the east, but kind of where you see the vending machines, that's where the bathroom area is. That's where those are. And you can get guest Wi-Fi on the Blue Zone network here. As I mentioned before, we're going to try and wrap it up promptly at 9:15. All right, so does anyone have any cases they'd like to share with us today? I'm going to switch over to the portal. And go to meeting, folks. If you're unable to talk and unmute for whatever reason, if you're able to type in the chat box, that works as well. If you can unmute and you'd like to say anything, please do. Just jump in and we'll be listening for you.
Hi. Let's see. I have a resource. I had a family that I was working with, and mother had an appointment over to LDS Hospital. Financially, they were really struggling. Have a car and the bus and that, and she was pregnant, and so that was a lot of the problem. But through IHC, the case manager, the manager within that department was able to get a voucher for Uber. So it's relatively new, and that struggle.
So do you think this is some sort of an agreement between LDS Hospital and Uber, or is this something that Uber is going to get?
I don't know. I spoke to one of the social workers, and they said that is something that they can do if there's a financial need and problem that the manager can somehow. I don't know.
It's within Intermountain. It happens at Intermountain Medical Center, primary. You go through the social work department, usually speaking.
Great.
We've help with clinic appointments.
That's fabulous. I feel like I saw something recently around the election and getting a ride to your polling place through, I'm not sure if it was Uber or Lyft, but I feel like these are doing more and more of these sort of charitable efforts around that.
I noticed.
Mindy, this is this is Mindy. This is Dawn. When I was at a conference in the spring, I met with people from Uber Health, I think is what they actually called it. So they actually do have a whole division of Uber drivers that they have a way to keep it HIPAA compliant and stuff. I'd asked about billing when I was there, and did Medicaid or Medicare cover it? And that was where it got a little tricky. And most of the clinics that were using some sort of voucher, and the clinics were paying for it to get the patient there to get the care that they needed, instead of having, chronic conditions kind of get out of control and stuff. So it is a division of Uber that they have. So.
Uberhealth.com.
Uberhealth.com. All right. Well, thanks, Walt. We will look into that and get that information into the portal services directory.
Lyft has one as well. I don't remember what it's called, but I know they have one specifically for medical, non-emergency transportation as well.
Okay, well, I won't take the time to look at that here, but that's exciting.
Lyft for Health.
Lyft for Health?
Lyft for Health.
Great. Okay.
Probably statewide.
Oh, I'm guessing it's beyond.
Yeah. But I mean,
So that sounds terrific. We'll look into that stuff. That's fantastic. Thank you. Thanks. I always love hearing about the new resources. Sometimes it's more a matter of if there's a roadblock that you're facing, somebody can jog their memory with a resource that's helpful for what you're facing.
So just a little bit about what we found out in this last week. So for kiddos that are eligible for an IEP, if they choose to go to a private school with the Carson Smith Scholarship, we had to get 2 different attorneys involved to really figure out the law, one from the State Board of Education, one from the Disability Law Center, because when the child went back into a charter, which is a public school, they felt like that the child, since he was on a special needs scholarship, that the IEP would still be in place, when in fact now the law has been, in this last week, been interpreted for us to say no, they actually void their rights for an IEP once they go into a private school regardless, which we kind of knew that, but we thought maybe the special needs scholarship would play into it. So for this particular case, it's a home hospital as well, and schools said, well, we can't serve because child doesn't have an active IEP. It's been over 3 years, so the whole reevaluation needs to happen. But so what's important to remember, which the attorneys said, let everybody know, it's like home hospital, if it's due to, of course, the acute need, such as the child had surgery and such, any child's eligible for home hospital. They only get like an hour to 2 hours of instruction per week, which is hard, but it's something. Whereas actual home, getting instruction in the home, specialized instruction, that would have to be through an IEP. And I think that gets so confusing for families and for those serving them. So if there are ever any questions about a child not getting adequate services, the State Board of Education says, please call the Utah Parent Center, because now we're all clear on it through many attorneys. So.
Great. All right. Well, I wonder if we should try and make some sort of a footnote.
Yeah. In our,
that is very confusing, and hopefully, not a huge setback in this particular case. That's good to know. Yeah. Okay. One is forearm, right?
So,
Kelsey in planning is joining the UCCCN meeting, but there's nothing set up. I think we have no planning on there. But she hears us. She can hear us, but she doesn't see, I believe. Yeah.
So Blanding, so she's in Blanding?
Yeah, she is in planning. She was just
Yeah.
texting.
She's in Blanding and she can hear us, but nothing else is happening.
So that's interesting.
Hi, Kelsey.
Hi, Kelsey.
Yeah, I can't tell that she's in that room. Seems like...
Is the Blanding one up there?
The Blanding is the center one.
Because she said she can hear us, but there's no visual.
So she might need to go find a, some sort of a technical person in that site. But I wonder, hey, do you mind running and talking to Brigham and letting him know that we think we have someone at Blanding who doesn't have
can hear us,
but not the visual. Okay. Kelsey, we'll try and figure that out. All right, thanks for letting me know. Okay, anybody else have something they'd like to share? A case that they are working on. We also really like to hear if there's any quality improvement wins that are going on, any efforts that are happening in your practice that you'd like to share. We had the asthma meeting in October, and I don't know if anybody was able to get some takeaways from that and start to use them in their practice.
I was hoping that BCB Pediatrics is present today, but I think the nurse is not here. But they just got recently certified as a PCMH patient-centered medical home, got recognized through NCQA, and that's a huge accomplishment for them, and I wanted to congratulate them, but they are not here. Yeah. So it's a lot of work, so we know and serve it.
Which practice was that, Gabby?
BCB in Bountiful.
Oh, great.
And I believe they became the first clinic in Utah who also got recognized for behavioral health integration.
Wow.
Mm-hmm.
Recognized by...
So NCQA.
Wow.
So
the payoffs for all that work are...
Well, that you have the recognition, that you are federally, really nationwide recognized, and hopefully down the road there will be maybe some payer reimbursement.
Right.
And also the payer for the practice themselves is they have quality improvement projects going on, all their processes are streamlined, everybody's following the same thing, and it ultimately leads to better patient care and better outcomes.
Great.
Mm-hmm. You get the little NCQA symbol next to your provider's name when you do a provider search. You're trying to search for those. You can also drill down on, like if you move to Utah, you can click like NCQA clinic, and so it'll only pull up those ones.
Yeah.
Yeah. So that was our goal, was that we wanted to...
And it's a lot of work, isn't it?
Yeah. And a lot of families actually know what it is. I think it's becoming more popularly recognized when you're trying to find a provider. Especially if you got kids with behavioral health needs, because you have to have the MHI, and then also children's special health care needs, because that means you're medical home.
Right. That's great. So about how long does the process?
It's about a 12 months, at least a 12 months process. Some practices need longer, and it's not cheap. It's quite expensive. But I think if the practice really commits to it, then they do it. Mm-hmm. And right now, university community clinics, they're all in the process of it, and also South Main clinics and Utah Pediatrics clinic is also participating. So we are right in the middle of craziness.
Insurances can too. Select Health is one.
Oh yeah. Mm-hmm.
Very good. That's exciting. Well, congratulations to Busy Bee.
Yeah.
Okay. Anything else? Well, that's all right. We can move into our main presentation, which, again, is about hospice and palliative care and goal planning. We're really glad to have Beth from Workforce join us today. Beth is starting to work a little bit less, and so we feel very grateful that we have her to be here with us today. I've seen a little bit of this kind of presentation by Beth a number of years ago, and it's just great stuff, and I actually feel terrible this group until now, but today's the day. It is being recorded as well for those who can't see it. Yeah, sorry, Beth, not to put you on the spot, but you're on TV. And Beth, because we have GoToMeeting involved in this as well, I can't do presenter mode. It just doesn't work for some reason, and so this is the setup we have. And I think if you just arrows or thanks very much. Appreciate it.
Well, good morning. Thank you so much for this opportunity, Mindy, and I hope that we're able to have some good discussion today. Stay close here, right?
Well, I'm happy to move the slides for you if you like me to. You can wander as much as you'd like.
Okay. I am a little bit of a wanderer, but I'll try and stay close. As we talked earlier, and Gina, it was brought to my mind that it's been about 5.5 years ago, maybe a little bit longer, since I did first presentation for what we called the medical home group. It's amazing. It was in a small classroom. Now, so many years later, I think, with the amount of work that's happened, and credit to Dr. Norman and staff for all that's happened, because this is such a needed. Grateful to be learning from you all, and I hope that you're learning as well. So I wanted to. This has all going up, and that's just the way it goes.
Yep, that's just the way it goes.
Okay. Well, let me go back one.
Can you do presentation mode so it's big?
So it interferes with GoToMeeting. Yeah, it doesn't work.
So you could tap on the Home tab, and that'll get rid of the ribbon, so it makes it a little bit larger.
Okay.
Then you could enlarge the slides a little bit. Get rid of the notes section too.
Chuck.
Sorry. There you go.
Also, when you wander, your audio going in and out. So if you stay closer to the... Sorry.
I'm very forgetful. Anyway, we will just go forward with this. I use the graduated font for a purpose. Hospice, palliative care, and goal planning are all very important things, very important topics that I could talk about for hours. But today I'm hoping to focus on the goal planning. We certainly touch ever so slightly on hospice and a little bit more on palliative care, because that is my area of specialty, but mostly about goal planning. So that's where I want to focus, because I think that that's what's most needed for us. So my first thing is, as you saw the topic, what were your questions maybe that came into your mind about what you would like for us to talk about?
Where to start? I guess, yeah.
It is really true. Where do you?
How do you bring up the topic? It's hard. If they're familiar with hospice or palliative care in adults, I think they up. You know that it's the end. It's different in children. So how do you scaring them?
Thoughts? Okay. So the next question that came to my mind is, why should we even be having this conversation? What we know is around 500 children die. That number fluctuates some, but approximately a fourth are from of some type or other, which are probably the type of kids that your practices focus on. At least that's where our area of focus is. Most of those deaths from these chronic illnesses happen in the hospital, and more often than not, For some families, that's where they would choose. And for other families, that's not what their choice is. Not like they have a choice. And another thing to consider is that approximately 1,500 kids are out within our community with these chronic illnesses. That's what keeps us in business. But it's also a situation that we need to help. So what do you think the supports are that we have for these families? Any ideas or suggestions? Sorry, did somebody say something?
Home health.
Home health. Great. First thing that came to my mind was all of you. Because here you are in this situation where you are helping families with these chronic illnesses, and how awesome that the medical home program has grown so much over the last 5 years. The next thing that comes to my mind is, of course, hospice and palliative care. Now, hospice is a situation where your hospice gets involved. The doctor has to say, well, it's possible that this child can die in 6 months or less. That's what it takes. It's the Medicare rule for qualification for hospice. It's awesome that you get care in the home. You have access to a doctor, nurses, social workers, chaplains. So that's awesome. But just like Corinne just stated, when families hear the word hospice, they do think. So we have to try and help families reframe that thinking to, I'm providing the best care in the best place at the best time. So as you were walking this path with your families, Corinne also said, how do you bring up these topics? I think the way that you are able to bring up these topics is by having relationships. See those opportunities when the door cracks open. Talk about that a little bit more as we go on. With palliative care, you can offer that at any age, any stage of the disease process, and we certainly prefer to have referred to us early in diagnosis, like as soon as they're diagnosed with a life-limiting or life-threatening condition. That's when we like to get involved. It takes time, doesn't it, to develop the relationship so that they can trust these hard conversations with. And offered with curative care at the same time. Now, some of us understand concurrent care, which is part of a hospice benefit from Medicaid. It's with the Medicaid patient hospice, and which is amazing. So, what is it that we provide? It's very interesting that I have dots and dashes. When I sent this to her, it didn't have dots and dashes.
Yeah, it does that. Hey, let's try this, and then you might even be able to wander. We can leave it on
If
here.
I get lost, will you come find
Yes,
me?
I will.
Okay.
Well, I can even hold on to this, and then you can't go very far at all. But, or you can attach that to you, or we can just set it
Okay.
down. But I think
Super.
having that near you is going to improve.
Okay. Think that helps? Okay, very good. What is palliative care? Oftentimes families, when they hear the word palliative care, just like Corinne just said, she's my stunt woman in the audience to help set me up. They often say, well, hospice and palliative care are the same thing, right? That's what you do. No, we're not just about end of life, or we're not just about hospice. And the way I like to describe it to families is, if you think of palliative care as a tree, hospice is a branch on that tree, but it's not the entire tree. Palliative care extends beyond that. And what our goal is to help families, and is this what you're trying to do, have the best quality of life possible for whatever amount of time that they might have. So our purpose is to improve the delivery of care to these children. We help the medical care providers as they are approaching a situation with a family, help them talk with families because somehow there is a language barrier about what their goals are, what's important to them, and then try and map the appropriate care for these families. We also help the families with that communication. Up at the hospital we have language services, and so when it's a different language than our own, we have them come in and help us, but oftentimes we're needed for that same purpose because what the medical providers are saying, they're not necessarily saying it in a way that the family can understand. And it's very interesting that the family, as they express what's important to them or what they think is a proper path of care, the medical providers somehow can't seem to understand what they're saying. So we do act as interpretation oftentimes, but our greatest goal is to assure that patients and families are understood with their goals of care and that those goals are honored. These are some of the chronic conditions that we often see. They fall within the cardiovascular area, neurodegenerative, metabolic, and another one that has finally popped up on the list as its own is about prematurity. That hasn't been in its own category. It's been in the other category, but we're facing those issues on a regular basis, and so that's developed its own category. Often we're asked to help families figure out what their goals are, and goals is kind of a hard thing and a word that many families don't understand exactly what we're saying. We help facilitate communication as stated. We often help with pain and symptom management, and families are often in psychosocial distress, spiritual distress, and we help them recognize what's happening and then try and help find the supports that they need. We also try and coordinate care across the settings. And that's one of the things that's really fun for me as I come here because I've called many of your clinics and said, hey, can you take this patient? This is what's going on. And which doctor is accepting new patients? And of those doctors, which one would be best for this type of situation? So I really appreciate your expertise in being willing to work with the families that we work with. Intermountain has kind of moved to one Intermountain, and so we are called the One Intermountain Pediatric Palliative Care Team, and we are working with the Utah Fetal Center, which is a clinic of about a year and a half old. So we get an awful lot of referrals from those clinics with babies who are diagnosed prenatally with life-limiting or life-threatening conditions. We also consult throughout the hospital. We're not stuck in one unit or another, but we're throughout the hospital. And we also we often have pediatricians call us saying, hey, I've got this kid. I'm not quite sure what the best way is to support this family. And they're coming into the hospital more often. Can you be my eyes and ears there at the hospital? Can we refer this kiddo to you? So that's been a great opportunity. The oncology department has decided to refer more patients to us, but they weren't crazy about the name palliative. And so they like their program called SOAP. It stands for Supportive Oncology and for adolescents and pediatrics. Sorry, I had to think about that for a minute. What does that stand for? And so we are the Rainbow Kids team, but as we go into the oncology department, we're the SOAP team. And they like that because it makes them feel like we're more a part of their team rather than a separate team, which we're all about. That's an awesome thing. We're just grateful to be in there and being able to offer services to these families.
You change your name tag and everything?
I'm sorry?
You change your name tag and everything?
No. But, it just says RN. It doesn't say palliative care or anything. I'm kind of lobbying for that to happen so that people know who we are, because suddenly there's this other nurse, there's this other doctor that shows up with this family, and who are you and what's going on? This is our team. We have 4 physicians. We have 3 nurse practitioners, 2 nurses, a social worker, and a chaplaincy. So we try and help families all across the board as far as what areas they might be struggling with. It was an interesting statistic to learn that we've been in business for over a decade. More than half of the kids that have been referred to us are still living. So there are the babies. Corinne used to work in the NICU, and we get a lot of babies in the NICU. And some of them live for a very short time, and some of them stay in the NICU for months and months and months, or a year. So it's a long time to be in the NICU. But it's amazing to me to see, and our patient ages go from prenatal to our oldest is 39 years old. And that doesn't include the prenatal moms. We don't calculate their ages within our patients, but we certainly count them for sure. As we started, we learned that historically about 80% of deaths of children happen within the hospital. And as we got our program up and rolling, we saw our families choose to be at home more often and to have their children die at home. So we have greater than 40% now whose families are choosing to be at home. And I think the best part of that, every family can feel differently about where they want their child to die. For some families, it's very difficult because they're worried about their other children and they want to have more support around them when their child dies. And so choosing the hospital or another facility is okay, but that they have a choice. And I think in the past, families haven't necessarily felt that they had a choice. They didn't recognize that they could possibly go home from the ICU with the support of hospice and be able to be home. But we're offering that to many families. In order for these families to have the kind of support that they need, we need both generalist and specialist palliative care providers, right? And as we've started talking about, I was trying to introduce the thought that you, with your patients, are doing some palliative care. You're talking to your families, you're developing those relationships, you're hopefully recognizing those opportunities to start introducing some of these hard topics, to be able to support families where they are, and to be able to make sure that they're getting the right care in the right place at the right time. The specialists are stuck up at the hospital. You're out there with these kids. We're a phone call away, and we're happy to help, even when the patient is not ours. We're happy to help you in any way that we possibly can. So there was one family that I went to, and I said, what is important to you? And Elizabeth was right there with Mom. And as we were talking, she decided to draw a picture about the thing that was most important for her. So her goal was Elizabeth this happy all the time. It meant she was comfortable, she could go to school, she could be with her siblings and play. So those were the things that were most important to her. Goals aren't necessarily, I want to run a marathon, or I want to be the Queen of Sheba. I don't know. But they're about simple things. Is your goal to be in your home? Is your goal to be in the hospital? And then as you face those different decisions that come up, maybe it's about a medication, maybe it's about a simple procedure or a complicated procedure. Does that procedure keep you on your path of your goals of being home or being in the hospital or a mix? Or does it take you away from what's most important to you? So that's how we try and educate families, that they need to figure out what's most important to them, and then as a decision comes to them, then it makes it a little easier to make the decision. Does this take me towards what's most important, or does this take me away from what's most important? If my goal is for my child to be awake and alert as much as they can, and a medication we're offering makes them more sleepy and less active, then maybe that's not the best medication. But sometimes we get to those places in life where we're not able to be as active, the kids aren't able to be as alert in order to accomplish the goal of being comfortable. So there are benefits and burdens of every decision that our families face. When families come into the hospital, they often talk about it feeling like a runaway freight train. And there's nobody in charge, or there are too many people that are in charge, and it's all confusing. So our goal within the hospital is to put them in charge of the freight train and say, okay, you're the conductor. You get to say how fast we go. You get to say where we're going. And so we all take a big deep breath and try and step back. And that's something that each of you can do within your practices too, as you have families come in frantically saying, well, this doctor wants to do this and this doctor wants to do that. It doesn't seem like they coordinate. And how can we figure all of this out? Code status. Like talking about that one? Kind of scary, isn't it? What's your greatest worry as you're talking to families when we mention code status?
They're going to think we've quit already.
Good point. They think that we, as their medical support, are quitting, giving up on their child.
By even bringing it up.
By even bringing it up. So some opportunities for you to kind of open that door a little bit wider is if maybe there's been a change in the care. Maybe this patient has gone into the hospital several times. Maybe parents are saying, gosh, things just seem different. Maybe they're starting to question some things. They may not say, so can we talk about code status today? But they may be saying, what do you think? What are you seeing? They may be asking you for your opinion of what you're seeing of their child. This is an opportunity for you to say other things to them. Are you worried? Tell me what your worries are. You know, as we all travel down I-15, there's opportunity to get off at 6 South as we're heading south towards Provo, or we can get off at 45th South like we did today. Maybe we head on down to 72nd South. There are those opportunities in every child's life too, and we need to be aware when an opportunity might present for us to have conversations. But why would you want to ask this? Many of our families are suddenly faced with crisis situations, and they're not.
What is a code status?
Yeah, we don't know what that is. I'm sorry.
So sorry. Okay, so code status is if your child were to have respiratory issues or found without their heart beating, would you want chest compressions? Would you want intubation? So a code status might be do not resuscitate, or it might be full code, which means do absolutely everything possible.
Yeah,
Okay?
it's derived from the term used in the hospital, what, code red. So what happens with
Code blue. Thanks for the question, because that's really important. It's hard to understand what we're talking about here, right?
What is that? I don't know.
So any other questions about that? Okay. When you're in the middle of a crisis, like your child is having a tough time breathing, it's really hard to talk about things and to make decisions in that circumstance, isn't it? But if you've had, yes?
I was just thinking, unless you're planning to get to this quickly, you might just run through, well, what are the various choices that are involved in determining a code status? That might help frame things.
Okay. It's so varied. It's a little hard to list it, but so would you want everything possible to be done, which means IV medications, chest compressions, intubation, and please pitch in if I miss something? Or would you rather make some other decisions? Would you want your child comfortable and supported, but maybe not with as aggressive treatments?
And kind of the balance is, potential pain and discomfort inflicted by the process of the code or the resuscitation, and the possibility that at the end of that they're still alive, but even a worse clinical situation. They might
But
be
their
brain
quality
dead,
of life may be very different.
and then now they might be stuck on a ventilator, and now somebody has to make the decision to stop the ventilation.
Right.
So I think those are the key issues going on: is how much pain am I causing, and what are the other decisions that have to be made later if this is successful.
Exactly. And parents aren't thinking about this very clearly, but I can assure you that they are thinking about this. And they worry, well, what will happen if this or that happens with my child? What am I going to do? How is that going to look? So I think it's very important for us to be able to give them as much information as possible. And another reason why, just as Dr. Norland was saying, we want to prepare our parents is because if they happen to be in the grocery store and their child has an issue, maybe they have a seizure, maybe they stop breathing, and somebody else calls 911 and the paramedics respond, they're under legal obligation, do everything that they can to resuscitate that child, regardless of what the parents say. They have to. There's a way that we can protect them, and we'll talk about that in a minute. Oh, maybe we'll talk about that right now. Oh, there it is. I know my slides well. A PULSE form is the form that you can fill out that would help protect a child from unwanted situations like that. Unwanted cares in a situation like that is the way I should state that. And we'll go into a little bit more, just like Dr. Norland was saying, for some families that's just not the best thing to have chest compressions. Maybe it's a kiddo with a heart condition and chest compressions are not going to be helpful and would only cause pain and suffering. Yes, ma'am.
PULSE stand for something?
PULSE does stand for something. Thanks for that question. It stands for Provider Order for Life-Sustaining Treatment. So that means a nurse practitioner, a doctor, a PA, those are our providers, the ones who can sign orders. That's what a provider is. Some people think that it's what a family like this needs is an advanced healthcare directive, but actually those are only for adults and they're awesome. How many of you have an advanced directive? Excellent, excellent. A few, not enough. Get busy, folks. Get those in place. Because it's important you can choose somebody to speak for you when you can't speak for yourself. And for the children that we work with, who speaks for them is their parents.
So let me ask you a question, because I was just in the hospital last week with my mom. She was in some heart failure, and they asked about advanced directives, and just the deer in the headlights moment, like, no. And they always say, would you like more information?
Yes.
And somehow through all of this, you do get some information, but I've never really seen, like, what is the next step to really activate that or say, this is how I implement this advanced directive.
So you can go to the website and print off a nice little information packet that will help you walk through filling out an advanced directive. It is a do-it-yourself type document, so that's awesome. But you also need a witness who's not related and who isn't involved in the care. When my husband had some surgery about 2 years ago and we were in the hospital and they asked us, do you have an advanced directive? We're too young for that. But they helped us with that and we both filled ours out. But they went and got the family member of somebody next door to come in and witness my signature. So it's very interesting.
Just to witness the signature. They don't even read what the
directive
is.
Yeah.
But it's exactly what's on there is exactly what like Intermountain Healthcare uses. If they were to give you more information, that's what they give you.
Yeah.
And it doesn't have to be notarized. It just
No.
has to be witnessed.
Just witnessed by somebody.
See, it seems like at some point then we get caught up in the minutia of being hospitalized for a few days, and then we don't think about it again, and no one died while we were there.
Mm-hmm.
So we move on, and then like we just never did it.
Yeah.
So yet again, the next time we go, do you have an advance directive? No, we don't.
Yeah.
And you can take it, if I don't know if you're at an Intermountain facility, but they scan it into your health record. So if you take it back to your doctor, they can.
That's the most important thing. It's really easy to fill it out and have someone witness it. But then if it just sits, a paper copy, it's no good. You have to actually take it to your provider and have them scan it into the
system.
Yeah.
Exactly. That's what is so important about this. But these conversations can be hard to have. I remember when my mom was ill, and I knew what was best for my mom, and so I started filling out a post form for her with a doctor. And as I got to a particular point in the document, I mean, it was easy for me to say, "Oh yeah, do not resuscitate, comfort measures only." And then I got to IV antibiotics. This was the old form. This was 5 years ago, and I went, I don't know. In this situation, I would want IV antibiotics, but in this situation, I wouldn't so much. And I was so surprised that it stumped me, who does these things every single day of my life. It stumped me. And my mother was 86. So if it stumps me with my 86-year-old mother, think of how our parents must feel. It is like a brick wall that they run into, so they really need our help to carry them through. When we talk about how do we have these conversations, there are some other helps. This is called 5 Wishes, and it's an opportunity for you to ask questions. My wish for what I want my loved ones to know, my wish for how comfortable I want to be. What should you keep in mind as a caregiver? What life support treatment means to me. So it's just an opportunity in somebody else's language to take to your parents, or for you to look at yourself and say, what do I think about that? But it stimulates those thoughts and questions and helps guide conversation, because these conversations can be very difficult to have, right? And this is a legal document in 40 plus states, but not in Utah, but it can still help.
It's a quick question. So advanced directives are only for people 18 and older?
That's right.
And what about 5 Wishes?
So 5 Wishes is also for the older people, for 18 and older. And these are instruments. These are not legal documents, but they can help you with conversation. This one is the school-aged child, and they can draw on it. They can write their names. Who should use my wishes? Why should I change my wishes? How I want to be treated. There's some check boxes. There's room for them to write some of their favorite things. You can pick up a lot of ideas about what a kiddo is interested in. My wish for how comfortable I want to be. We've given copies of these to some of our families who were very perplexed about what the best thing to do for their child was. Maybe their child with complex needs was younger and there were older kiddos. They did this kind of like for a family night and said, okay, what would you want? What would be important to you? So that it draws the whole family into talking about this and recognizing we don't know what's going to happen, but we know something could happen because of the illnesses that our child has. We like the language in this Voicing My Choices the best. They're all put out by the same people. But this is the teenage volume, and the language just is a little bit better. How I would like to be supported, how I want to be comforted, and then the different choices and places for them to write and fill in. So if these are things that can guide you, they aren't legal documents, but they can help guide you, and they are amazing tools as you look through some of these things. Know that a PULSE form is transferable. It doesn't matter whether at our facility or at IMC or wherever at, I can't think of any other hospitals. St. Mark's, thank you. Wherever the PULSE is legal within Utah, wherever you go. Others, yes. And it is, know that a PULSE form is for in the community. It's to help direct care within the community. If you have a PULSE form and it shows up on your electronic medical record as you go into the hospital, it should also help guide discussion, but it doesn't necessarily, because most of our families choose to have a different code status in the hospital than they do outside of the hospital, because they recognize that within our hospital we have all the specialists, and maybe we could do some more of these aggressive cares more expertly than a paramedic who hasn't ever done CPR on a child before, because usually he's dealing with adults. So he's not going to be as practiced as someone in our hospital. Also, they might be coming in for a surgery, and of course they want this to be helpful for their child. So their code status would be very different on that admission maybe than if they came in extremely ill and not sure how their child may or may not recover. We're going to get into the PULSE form. Let's see where we're going to do this. It has to be filled out by a licensed person, a nurse. Social worker can help fill it out. Has to be signed for pediatrics by 2 physicians. This is not a do-it-yourself document. You can't cross something out and make a change. You have to fill out a whole new form. But it's what you can do. If the form is filled out in a particular way, you can say, forget this form. Please do everything possible. So parents always have a choice. But I want to talk to that too.
So, sorry, you said it had to be signed by 2 physicians?
2 licensed providers.
2 licensed, so it can be a PA and their doc or something.
Or a nurse practitioner, 2 nurse practitioners, just a licensed provider. Not every state has a PULSE form, but most states honor them. And if they are going on a Make-A-Wish trip to California, California honors our PULSE forms, just so that you know. Idaho does, Colorado does, Wyoming, a little edgy, but I have had families travel to Wyoming and had the doctor say, oh, okay, I see that this is what you're thinking. But they just don't have that as documentation in their state. So it's just a little bit different there. So this is the old form. This is the new form. Demographics up here, and a place for you to say what the goals. You're going to give me a 5 or 10 minute notice,
I will.
right?
Yeah,
okay.
You're fine. You got
okay,
to do that
cool.
sometime.
And I think it's really important for you to write in a goal, and maybe that goal is just comfort for this child. I mean, it doesn't have to be complicated. There's a place for the diagnosis or what the condition is, and it's important to state there, you know, what the most impactful diagnosis is, because most of our kids have more than one thing wrong, and in a way that a paramedic or somebody might understand. So it doesn't have to be the technical terminology, but Part A is about if your child is found without breathing and without a heartbeat, do you want to attempt to resuscitate or do you not? Part B is about your medical interventions. Do you want full treatment, which would be intubation, chest compressions, the whole ball of wax? Would you want limited interventions, which might include treatment of an airway obstruction, bag and mask, let's see, IV fluids, IV antibiotics, that would be that. Or the third option here is comfort measures only. Some of our families say, they start looking at this and they think, oh, well, you know, yeah, I don't know. It just depends on the circumstance. We've always called this an insurance policy. This is your opportunity to be empowered in the moment to make choices, because without this, it is go for broke. It is every possible medical intervention that they can do in the community to get you to a hospital. And then once you're there with the doctor, you can then make choices for your child. But as we were introducing this to one of our dads, a very young dad, a dad who was in school in pre-med, but so he was very, very smart. And he goes, oh, I get what this is saying. I need to fill this out in a way that empowers me the most. So I'm not going to think about, well, what if my child does this? Then I would want this. And if my child does this, then I'd want this. He goes, I'm just going to fill it out in the way that empowers me the most, which means you put do not resuscitate and comfort measures only. And in fact, I just had this conversation with a mom last week, and she goes, oh my gosh, thank you very much. I can fill this out now. I haven't filled this out because this was too scary, and this felt like I was giving up on my child, rather than empowering myself to be able to make decisions if something were to happen. So that's what we want this form to do, is to be a relief for parents, to be something that they can pull out. Most of our parents have known when their child was nearing the end of life. They don't always want to believe it. They don't want to accept it necessarily, but they have a sense. And when that last event happens, they have an idea about how they want that to happen. This gives them the opportunity to implement what they think is in the best interest of their child and prevent.
So saying that on the form, then in the event they can say, oh no.
Right. You can be more aggressive than you put on the form, but you can't be less aggressive than you put on the form. That's why saying comfort measures only and do not resuscitate empowers a parent, because maybe this isn't their child's dying time. Maybe they just swallowed a hot dog or something, you know, and so yes, we think that we can get over this and we will have the same quality of life as we have had, and it's been a good quality of life. So it all depends on where the kiddo is and what the circumstance is, but this is a good thing to have, and you can't get this too early. This is always a good thing to have and to introduce to families.
Do you find at all that parents are worried about what we think if they're thinking about this, and how do you deal with it? What do you say?
So I think that, especially I see this in the oncology area, I think that families want to keep fighting because their team is still fighting and they want to stay in the mix, and they don't want to disappoint their caregivers. I think that sometimes we are more afraid of talking about these issues than they are. I think that our parents are looking for opportunities to talk about what their worries and concerns are. And that's a simple question you can ask them. What are your worries? What are you most worried about? That's not a threatening question, is it? It's not like saying, what's your code status? You know, but that lets them know that you are with them wherever they are. And I always say to them, we will support whatever you put on this paper, but it's important for you to understand what this paper can do for you and what it can't do for you.
Okay.
Another question?
I'm thinking about, okay, in the pediatric clinic setting, and of course, obviously at that point, they're not in the hospital.
Right.
You know, at what point do we bring that up? You know, and I have a couple of kids in mind right now that I'm like are in and out of the hospital, and certainly we've had many conversations with their primary care providers where I'm like, you know, where we know, you know, they're not long for this world.
Right.
You know, and parents are at varying levels of acceptance and what they want to do. One where he just had a massive code and he's in the hospital and he has broken ribs bilaterally all over the, you know, multiple. And I think he's in so much pain.
Right. So I think that there are many families, and this was my mother sitting in the doctor's office, and she goes, "Do I need my mammogram?" And the doctor said, "Well, that depends. If you were to get breast cancer, would you treat it?" And my mother is saying, "I'll do whatever you say, doctor." And I'm over behind her going, "We're not going to treat this. We're not going to put her through that at 86 years old." So I think that some people these are the doctors and they know what's best, rather than saying, "I know what's best for my child." The doctors can offer information about what the latest treatments are and what might be helpful. So, maybe they don't even recognize that they have a choice. So I would say to them, "Wow, I heard your admission was kind of rough. What did you think about that? Was it hard for you?" And as they start to talk a little bit, was it hard for you to see your child going through this code? And get them to talk. Well, is that what you want to have happen if that happens again? And then maybe they'll say yes or no. Most of our families who've ever seen an IO, it's an interosseous, oftentimes kids, you can't get IVs in them when they're very, very sick. And so they stick a big needle through one of their bones in order to be able to give lots of fluid quickly to resuscitate them. Most of our parents, when they see an IO done on their kid, they never want to have anything like that done again. And so they are willing to talk about what just happened, how hard that was, how hard it was for the rest of the family to see some of that stuff. And then they want to make sure that kind of thing doesn't happen again to their child. And many of them will put no IOs on this paper. Yes, Dr. Norland.
I think that kind of presenting it as lots of families in your situation, with kids who've been through, even if it's not a code, who are sick or having this kind of problem, they wonder what the future is going to hold and how to make decisions, if that time ever comes up. So kind of approaching it as, well, everybody thinks about this, but it's oftentimes really hard to talk about. So whenever you want to talk about that, let me know. We're happy to sit down and listen to you. So I think approaching it in that way so that I guess everybody does think about this. Yeah.
And that they can come to it in their own time. Right. Yeah.
Yeah. And then remind them every once in a while. We talked about this before, because I think you're right, it is hard to come up with it. And if I heard your previous question appropriately, is the concern about, well, what am I telling doctors about how much I care for my kid if I talk about this?
Right.
I don't know, could you address that, Beth? Kind of how do doctors feel about, parents who say, well, maybe it's time to let my child go or something like that?
So oftentimes one of the things we say to families is we understand that the decisions you make are made out of love for your child. So I think acknowledging the care that you see within families really helps them know that you know their heart and that you know the decisions that they make are that they're trying to make the best possible decision for their child. As you were talking, I was thinking of oftentimes the way we present this is, families in similar circumstance would choose differently, and there's a whole spectrum. And I've got had one dad he was a street fighter. That's the way he earned his money, was as a street fighter. And his child had an irreversible, very life-limiting condition and was in the ICU, intubated with this huge belly. And the ICU docs were trying to get this dad to make him a no-code, to make him DNR. And he said, "We're a family of fighters and we fight to the end. And as long as his heart is beating, then we're going to do everything possible. And if his heart stops beating, then I want you to help him beat." So the only place we could help this family get was to say, okay, so we will try that, but we'll only try that for 5 minutes because we're worried about the suffering it will cause your child. So that's the extreme to this direction. And the extreme to this direction would be a family who says, you know, I know that my child, and I've always known since diagnosis that my child would have a shorter life. And so we just want to be able to be home. We want to stay away from the hospital. We want our child to be as comfortable as possible, but we're going to choose no aggressive interventions. And then there's everything in between. And if you let families know, we will support you whatever your wishes are, but we want you to understand that you have choice and that you can see where your child is. If their child has a great quality of life and they bounce back after hospitalization and they're still off to school or doing the things that they enjoy doing, then that is a life worth supporting with aggressive treatments. But aggressive treatments bring burden, and it's understanding what those burdens may be, because oftentimes we don't think about it. There's a statistic that says that families who see what CPR really looks like in real life, not what it looks like on TV, and the person is up by the end of the segment and he's feeling fine and good and out to go save the next person, when they see what CPR really looks like, they don't choose CPR for their family, for themselves. They say, no way. I don't want that to happen, because the chances are ribs will be broken, lungs can be punctured, and then you put a child in even a greater risk. And the numbers are very high that CPR in the community for a child that is medically complex won't be successful. It's less than 20%. So when families understand those numbers, they make different choices. Approaching them with, what do you understand, or what are the doctors saying to you about his prognosis? What are you hearing from them? Well, maybe that's a question we need to ask, whether it's your doc or it's a different specialist. Maybe that's a question we need to ask and pursue and see what they're saying. But for some families, they would choose to do all of that again because it's what they feel like they have to do for their child.
Something I think you mentioned when we were talking earlier, but it doesn't mean that you're giving up hope.
No, it isn't about giving up hope. It's hoping for something different. You're hoping for the best quality of life. You're hoping for comfort. You're hoping for time. Whatever those hopes are. But that, again, is another good question to ask families is, if they don't understand what are your goals, then you ask what's most important, or you ask, what are your greatest hopes for your child? We had a mom in clinic the other day who wants her child to be able to sit, and the neurologist is telling us probably ain't happening ever, ever, ever in this kiddo's life. But we're going to hope for that with you, and we're going to make sure that you have the physical therapy that you need and the occupational therapy that maybe you need to see if your child can get strong enough to be able to hold their head and be able to sit up. So we hope with them, but also understand, well, you know, PT is tough. You're having to go to a different clinic. Does that work for you? Or would you rather just learn what you can from a clinic visit or two and then stay home? You know, because every treatment carries a burden. And for some families, going to PT is over the top for them.
Beth, just a couple more.
Uh-oh. Okay. So one way to talk to families, too, is what are your spiritual beliefs? Now, many of us are very afraid of talking about that, too, but there are many people with many different religious backgrounds. This is what drives their medical decision-making. So it's important for you to ask, do you have a strong faith belief? Do you belong to a community? This is called FICA, and I didn't get the lady's name on here that had developed it. But these are other ways to get to know your families better, to understand what motivates their decision making. I've got a case history, but it might be better for us to just bug out on that. I'll just tell you quickly, this was a 15-year-old kiddo with Duchenne's muscular dystrophy who was here from Wyoming, came in with pneumonia and a couple of other things that were going on. And it was obvious that this kiddo was nearing the end of his life. Not that he was dying right now. He was a big boy. He stood 6 feet tall and he was very heavy. And Mom was this little bitty petite thing. They lived in an upstairs apartment. And the thing we kept hearing from Mom in our meetings was total exhaustion, emotionally, physically, not being able to move him, not being able to get him out to school because his wheelchair wasn't working right. And, there were just lots of issues. She was somebody who had no support. And this was before the age of care coordinators and pediatricians' offices. And Wyoming is a little slow on that kind of stuff, too. So as we talked to her, her goals were to have him transferred to a care facility because she just could not do this anymore. She needed help. His goals were, I want to graduate from high school. And I want to be with my friends and family, and I just want to go home. I just want to be home with my mom in my own bed, and that's what I want. Their goals were conflicting. So we tried to help shape that into a situation where he wanted to graduate from high school. We knew he couldn't make that, but we could help him graduate from junior high. And we got the educational specialists involved, the principal of his school. We set up that situation. We got him in a care facility close to home, got the school to rally. Friends came to visit, family came to visit, and he died in that facility, well supported and very comfortable. And his mom got the support and help that she needed. So it wasn't perfect for him. It wasn't completely perfect for her. But we found a way to have their wants and desires voiced and supported. Our hope is that we add life to a child's years, not just years to a child's life. So that's our goal. Any other questions or concerns? Yes, Dr. Norland.
So one of the situations, the advanced directives are for kids 18 and older. What about youth 18 and older who aren't competent, who have intellectual disability, et cetera?
So hopefully you help families with guardianship for that. And the parent or the guardian, whoever that is, becomes the spokesperson for this person who's over the age of 18 and can't speak for themselves. They have the legal authority to speak for them. But a POLS form works for adults with just one licensed provider signature, and it works for children with 2 providers signing that. So a POLS goes across all ages. Advanced directives are just for adults who are competent to speak for themselves. And then these books can help guide and direct discussions.
And PEDS being defined as 18 and younger for that POLS form as a 2 provider. Okay.
Mm-hmm. Under the age of 18. Once you're 18, you're an adult. You're not, but you're an adult.
Right? Yeah. Not. Yeah.
So a guardian can fill out an advanced directive for the person they're guardian.
Mm-hmm. Mm-hmm.
And the POLS form then, kind of the reason for our 2 clinicians' signatures is to make sure that this has been done in a reasonable, rational way.
Right.
For on behalf of the child.
Yes. Yes. I look at it too as a statement of we as parents have had these hard discussions with medical professionals, and this is what we think is best for our child. I also think it adds, especially if you're in an emergency setting and the parent is saying, we've got this POLS filled out this way, but we'd really like you to do this more aggressive treatment. I think it adds validity. Well, these guys have already had these discussions. They know their child. So that's my personal opinion. I don't know how it carries, but.
I just offer one other consideration about thinking about, well, what do physicians think about this? So if we approach this, that as long as you're in your primary care setting, we know you don't have to worry about that kind of stuff. But what if you go to the hospital or emergency room? They're just doing their job.
Right.
Do everything they know how to do. So if you don't have this communication, then they're just doing their job.
Exactly.
They'd love to know what you want.
Exactly. And I think another way you can prepare families is if a child has gotten really sick and you're going to ship them off and they are a kiddo with medically complex stuff going on, you can warn them, hey, when you get to the hospital, the doctors are going to say, what is it that you want us to do? So this is an important thing to think about with any medically complex situation. They're going to ask you, if something were to happen, would you want us to do chest compressions? Would you want your child to be intubated? And some families say, yeah, I think this is just a respiratory thing, so intubation is okay, but yeah, I'm not so okay with chest compressions. Everybody can be all over the map with some of this stuff. But the more prepared, tell your families you're just being a good Girl Scout or a good Boy Scout. You're trying to be prepared and helping them be prepared so that whatever questions come their way, it's not the first time they've heard it, because this is hard stuff.
Thank you, Beth.
Absolutely.
That's wonderful. Mike and Gina, do you want to come up? And then would we be able to get a link to these forms?
Sure.
Okay, that would be so great. And we'll send that out.
Can you unplug me?
Yes,
Apparently I can't.
Let's see. It was a little tricky. There we go. All right. Thank you so much. It really is so important. Oh.
Okay. And I don't wander as much, and not all who wander are lost. So this actually, being quick to try to end at 9:59 will help me, because I'm taking my hat off as Family Voices as Utah Parent Center, and I'm going to try not to get emotional, because as many times as I've gone through this story, sorry, Wasatch Pediatrics, they've got to spend an afternoon with me not too long ago. But things that Beth hit on. So I'm one parent, one household, 2 different deaths, unfortunately, with my children. And so I want to hit on the points, especially with medical home. And for me, it's been long enough. It was before medical home was a term. But we, in fact, did have a medical home. So for my oldest child, because of the unknowns, and he was intubated at a very young age, not knowing whether it was flu symptoms, whatever that may be, we chose some very invasive technologies, such as being ventilated and eventually having a trach and life support at home. That was pretty. That was our normal life. And then when we went on to have other children, my third child, unfortunately, was also showing some signs and symptoms very different than my first child. And so with my medical home team, it was about, looking towards the future. And Beth and I have talked about this, and I was one of those that was very reluctant to fill out any form, because it was I'm giving up on my child. And for me, I did worry about, but on the other end, it's like my oldest child was already ventilator dependent. And I was thinking, they're going to keep thinking you're doing too much, because we don't have the unknowns. We know it's some rare genetic condition. And I was always second guessing in the back of my mind. But my oldest child actually on the ventilator was the easy one, because he had that life-sustaining support. But I did think every single time we thought about a hospitalization, one of the things that we were very fortunate is because we had great medical home team that back then, I almost want to say it's back in many of you might not know, Marcus Welby MD days, where, our pediatrician did make house calls. He didn't get reimbursed for it, but he did. And we were out of the hospital, and then we eventually got home health. One of the things that made the biggest difference was in thinking about Tyson. He was happy. We were good to go. Brighton, my third child, very different. He was very verbal. Kind of told us how painful this disease was. And I found out because my whole thought process was, there's not anything worse than burying your child. There is something worse. It's when they're in so much pain. And as a mom, you can't get them out of that pain. And so I had to rethink. And the one thing that my doctor's office did for me is they allowed for me to make a visit just for me. And, it was billed on, for Tyson and Brighton. But I went in feeling so guilty because Brighton was in so much pain and could tell me. And I said, but he doesn't want to be on tubes. What does that say for me as a mother? I'm not going to put him on tubes. How can I justify that I don't put my third child on a ventilator, but I put my first child? And he just looked at me and says, we have so much more information. They're two very different children. And we made our choices like that. Brighton, of course, my third child, because we did not do any invasive technologies. But we had the discussions. We decided no CPR, nothing. Because unfortunately, this disease also made very brittle bones, so any chest compressions at all would have been awful. But the morning that Brighton was passing away, I did call my doctor and I said, this is it. And he says, okay, we've talked about all of the situations of how the end of life can go, which I was horrified. And he says, I'm on my way. But he gave me that permission. He said, Gina, at any time you want to change your mind, you have every right to call, 911. He said, just remember, they will do everything in their power to save him. And that was not, of course, what we wanted at that point. Poor guy had told us how much pain again he was in. So, but him giving me that permission took that guilt off of me as a mom for everything I had done and everything all the choices that we as a family had made to be okay with. And luckily, both end-of-life situations were at that point where if you can have a good end-of-life experience, being a mother, watching your child pass away, we had those. And it was thanks to the medical home team, my pediatrician, because all the information, and he had to give it to me over and over and over again because it's like, nope, not signing that because that means I'm giving up. And it was finally, we may not have had for Brighton that form in place, but we definitely had it for Tyson. And the only other thing I can say is to remember the siblings in all of this, because all the choices we made, I forgot about the siblings. When Brighton was passing away, I went ahead and they didn't know anything different. I sent them to T-ball. They come back and their brother was gone. Worst mistake ever. By time Tyson was passing away, we knew more, unfortunately. And so I think we talk about the parents and the grief and all of that, but we have to remember that it's the whole family unit, and that was a piece that I think we keep forgetting is how it impacts the siblings. So don't want to keep going on and on. And on a good note, I mean, families are really resilient. I'm one family that chose at home, and that's where we needed to be. Every family, meet them where they're at, because this has happened a long time ago. This is something I have to live with every day, and it's right there. So families will do that forever. Okay. Thank you, Gina.
Natalie says, thank you for sharing your story. It's very powerful. Yeah, I think we all feel that way. The one thing that we'll put in the notes, and I just want as a takeaway, is that even though it might seem a little counterintuitive with the pulse, if you do the do not resuscitate and the comfort measures only, you can always go up. You can always go up, and you can always change your mind. But if you say do everything and they start doing everything, you can't take that away. So it does feel a little different, but it's actually the most empowering thing is to say least possible treatment and then go up from there. And every moment, every situation is different, and you can think about it differently, and you can always have that permission to change your mind at that time. So, okay. Wow. A really timely subject with Thanksgiving. We'll say
Your meeting has ended.